Hey everybody, welcome back to the ECG of the day. My name is Reid, and before we get started, feel free to download the PDF, which is linked in the description of this video. And while you're there, if you wouldn't mind giving this video a like or a subscribe, it would really help for the channel. So, alright, let's go. Let's get started. So first thing I'm going to do is look at the forest, and the trees of the forest are my QRS complexes. So I'll maybe pick a lead here and start to get a grip on what's going on. What you'll notice is in this rhythm we've got a regular wide complex QRS, and that wide complex QRS does seem to be nice and regular throughout the entirety of the rhythm. It appears that we've got some P waves before those QRS complexes, so that's reassuring. And yeah, like we said, pretty wide, right? So I'm starting to kind of work through our differential. Is this a ventricular arrhythmia? Is this a normal sinus rhythm with some type of aberrancy? What's going on? And so let's check out what the P waves are doing. Let's check out what the atria is doing. And so yeah, I do see that we've got these nice P waves in front of all of my QRSs. So it does appear that the atria would be driving this rhythm. My P waves, if I look, they are upright in lead 1, although just a little bit, and they are also upright in AVF. And so these P waves appear to be coming from my sinus node. These are sinus P waves, and they behave like sinus P waves, right? If we calculate the rate of these P waves, or the rate of the rhythm, maybe this QRS right here, I go 300, 150, 100, 75, about 60 beats per minute. That's about on par with what a sinus node would do, right? So you kind of put all this together to understand that you're just trying to mount a bunch of evidence to make your conclusions, right? And so we got what appears to be a sinus rhythm. Let's see if the AV node is working well, and so we're going to look at our PR interval for that. I like to find a lead that's got a nice spiky P wave. And so maybe, I don't know, it's kind of, maybe we'll just use this lead. And so we've got what appears to be QRS that starts there, a P wave. It looks like my PR interval is on the upper limit of normal, but I would say my PR interval is within 200 milliseconds, which is 5 little boxes, and so I'm okay with that. We need to make sure that the PR interval, though, we're only looking at one isolated beat. And when you're talking about the PR interval, I like you to think about it. Instead of it being the PR, think of it the AV node. Is the AV node functioning in some predictable fashion every time, right? We can't just measure one PR interval to do that. And so you kind of just look throughout, scan throughout, and you make sure there's no dropped P's. Every P wave has a QRS. AV node's working every time. There's no P's kind of in the middle of this rhythm that seem to be non-conducted. You might be like, well, is this a P right here? Well, what you can do is you can look straight up and say, oh no, that's actually just the T wave of my QRS, right? So use some context clues. Next thing we'll do is we'll evaluate that QRS. And so my QRS we said is wide. So if we measure it here, it looks to be greater than 120 milliseconds. So my QRS is wide. And so what's my differential for a wide complex QRS that occurs after a P wave? Well, there could be like isorhythmic AV dissociation. This could be a ventricular beat. I would say that's very unlikely for these QRSs to be coupled just like that, especially if there is a pattern of aberrant conduction that is known to us, like a bundle branch block, right? So things that would create a wide complex QRS would be things like bundle branch blocks, right? And why do they cause wide QRSs? Well, bundle branch blocks, either the right or left, are essentially going to slow down conduction through the ventricles, right? We think of a QRS being narrow because this AV node passes signal down nice and rapidly. But if you block one of these, then it's going to take a lot longer for signal to go cell to cell through the ventricle. And depolarize, it's going to take a little longer. And so in the setting of a wide complex QRS that seems to be driven by atrial rhythm, we think, oh, there's probably some aberrant conduction. And so what you do notice is that for my QRS, first thing I'll do is I'll just maybe do my axis. My axis is upright in lead 1. And I'd say maybe somewhat isoelectric in AVF, but you can see it's going towards lead 2 and towards AVL. So I would say, this axis is probably somewhere to the left, just like that. It's not a left axis deviation, but it's a little bit towards the left. And what you do notice is when I look at those lateral leads, my lateral leads are leads V6, V5, V1, and AVL. What you'll notice is that we've got this kind of slurring force that comes back. And so that's kind of a little bit of an R prime type of morphology. We see that here in V6 as well, where you get slur. It takes a little bit of time for that QRS to return back to its baseline. And that's very, very classic for a left bundle branch block, because we're having late forces in the lateral leads, which is what the left bundle supplies. We also have in left bundles, we lose this R wave. We have loss of the septal R wave. Let's briefly talk about that. So the left bundle, if you look here at our transverse axis, where you'll notice we've got our limb leads, our precordial leads. And so remember that the left bundle, so this left bundle here, it has these tiny projections that come off. And so that when the AV node conducts signal down the left bundle, the first thing to depolarize is the septum. So a left bundle depolarizes the septum from left to right. And that's the first part of the ventricular myocardium to depolarize, and you get these little R waves, right? You get these little R waves in V1, and sometimes a little bit in V2. But really, these R waves, and I'll kind of overlay them in red, that's my septal R wave. And so that tells me that the ventricular septum is depolarizing from left to right towards V1. Notice in left bundle branch blocks, though, we have a block right here at the left bundle. And so that signal can't get down to the left bundle. And so we actually lose that septal R wave. So that's why we lost the septal R wave in this QRS complex. And then also think, if we block that left bundle, we're going to have signal coming down fast to the right ventricle, and the right ventricle is going to depolarize rapidly because the right bundle is healthy. But what's going to happen is that left bundle is unable to conduct rapid signal to the ventricles, and so through cell-to-cell junctions, we're going to get late forces heading into the left ventricle slowly, 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 and so the lateral leads are going to pick that up. V5 and V6 are going to pick that up and kind of look the way they do. We get the same thing over in our lateral leads in the coronal section, where it's leads 1 and AVL that are picking up the signal originally going fast into the right ventricle and then slowly to that left ventricle late. And so you get these characteristic slurring of that QRS in our left bundle branch block. And we have that here. Our left bundle, we've lost the septal R wave, and we have slurring positive forces in the lateral leads. And so when we now kind of start to look for ischemia, now we've diagnosed our patient with left bundle branch block, we can look for pathological Q waves. It's kind of hard in the setting of a left bundle. You already have a little bit of apparent conduction, so you might say maybe there's a pathological Q wave here in the inferior leads of lead 3. Maybe there's one in AVF. It's hard to say. Honestly, the best thing to do is try to look at some previous ECGs on file and compare. And then lastly, we've got ST and T wave changes that we need to evaluate for. And just like in our pacing, we have a criteria for that. It's called Scarbosa criteria. Scarbosa criteria, which helps us evaluate for ischemia in the setting of a left bundle branch block. Because in left bundle branch blocks, you've probably noticed that we've got this kind of strain pattern where our ST and T waves, our T waves really will kind of invert. All right, we've got this QRS, and then we have a strained T wave. That's because of the aberrant conduction. So there's not new, but different criteria to evaluate for ischemia in those patients. I don't see any here. And so let's put that all together. We've got a sinus rhythm at a rate of 60 beats per minute. we have a left bundle branch block. So I hope that helps. And if you have any questions, throw them in the comments. If not, thank you so much for coming to the channel, and we'll see you tomorrow. Have a great day.